Today we have a question that should be answered about the IV albumin infusion. Our agenda will go through from the protocrete ending by the albumin infusion. Is it okay or not? So, is IV albumin infusion, is it useful or not? Or it is harmful or of no value? And subsequently, we will have a long road of a pathophysiological way to decide by yourself that if IV albumin is of usefulness or not. So let us go to the hematocrete and the protocrete. A protocrete is the function and the fraction of the proteins referred to as a protocrete and can be estimated from plasma proteins by the equations multiplying the odd ratios that of 0.0007 multiplied by the plasma protein concentration. And this modifying the oncotic pressure of the plasma, subsequently the cells and interstitial fluid. The protocrete behavior has two significant changes inside the dialysis or extracorporeal circuit, where it increased water movement from interstitium. On the other hand, it decreased dialyzer ultrafiltration as exactly in hemodiafiltration. So in hemodialysis or hemodiafiltration, we have a protein contact just adherent to the dialysis membrane in the boundary layer, and this protein contact mainly of albumin, and it decreases the ultrafiltration. Subsequently, the predominant cause of hypoalbuminemia in dialysis patients is the reduction in albumin synthesis rate and an increase in the fraction of the vascular pool catabolized per unit of the time, both driven by the acute phase protein. So we have a negative as well as a positive active process for the acute phase proteins. Albumin is a negative acute phase protein, while cytokines like interleukins and tumor necrosis factor are positive. So inflammation and sepsis with altered vascular permeability to albumin, meaning that albumin in plasma are translocation from the pool of the intravascular compartment to the extravascular compartment, while the liver function is inflamed. Inflammation, malnutrition, and dietary intake has a negative impact on albumin synthesis as well. Albumin loss in dialysis is minute in hemodialysis. However, in CAPD as well in the nephrotic syndrome are equivalent and may exceed more than 30 to 40 grams per week. The capacity of the liver is at that time is more or less to be increased, doubling the production. So albumin in hemodialysis, there is synthesis, loss in dialysate, nutritional status, inflammations, and finally dilution from volume overload. We will highlight how it is dilutional factor. So the increase in catabolism and loss of serum albumin due to renal disease and inflammation is a major factor in hemodialysis patients with the hypoalbuminemia. Slipping through the pores, hypoalbuminemia, because of the shape of the heart shape of the serum albumin, can go through the pores, particularly in convection therapy or in high ultrafiltration rate. In dialysis modalities, the medium cutoff and the high cutoff are the extremely high loss of albumin and significantly can decrease the serum albumin on the prolonged use of such a membrane. So consideration of serum albumin, albumin is produced by the liver. It is more than 585 amino acid sequence, production about 12 grams per day. Albumin, 4% is degraded daily, 40 to 50% is located in the intravascular, while the rest is distributed between the interstitium as well as the skeletal muscles. So the maintenance hemodialysis patient with the dilutional effect, each 0.8 liter in plasma excess 2 liters in the interstitial fluid. And the albumin concentration differs. So measuring serum albumin pre and post dialysis will differ significantly due to the dilutional effect. The 4 gram per deciliter will be reduced to approximately 3.2 gram per deciliter between pre and post dialysis period. Albumin transcapillary escape, 5 to 7% per hour, increase in hypervolemia will recirculate to the plasma compartment mainly by lymphatic reabsorption. Increasing that inflammation because of the leak of the membranes of the interstitium, as well in the interstitium, there is increased in the fraction catabolic rate. Hypervolemia in hemodialysis would induce movement of albumin from the intravascular to the interstitial space. Regarding red blood cells, it's 70% components of the water, and high water are re-equilibrate very rapidly in the isotonic solutions. So in health and inflammatory conditions, with excess catabolism, vasodilatation, increased transcapillary, and anorexia are the major four causes of hypoalbuminemia in maintenance hemodialysis patients. The liver can compensate up to 12 gram per day production. However, albumin movement, we cannot withstand the IV albumin or the albumin infusion inside the circulation because movement to transcapillary are increased in inflammation and vasodilatation. So what about the hypotension, intradialytic hypotension? And what is called is the renal replacement therapy associated hemodynamic instability, the blood pressure and volume management conclusion from the KDIGO. Lastly, that short-term risk and long-term risk of intradialytic hypotension and euvolemia to reach is the important factor why hypovolemia on one side and hypervolemia on the other side has a risk of death. The consequences of blood pressure and volume abnormalities in dialysis and the patient-related factor مهمين جدا. البور ultrafiltration tolerance, higher intradialytic with gain, autonomic dysfunction, heart failure, vascular stiffness, and atherosclerosis. And we have to move to the intervention according to the patient-related factors. We can move to more prolonged dialysis or hemodiafiltration. We can induce that by many factors. So the conceptual framework for individualizing dialysis prescription, especially in patients with inflammation and hypoalbuminemia, is essential. With the dialysis-related consequences, it's our job to individualize hemodialysis for those patients. So patient consideration like age, size, lifestyle, comorbidity, cardiac dysfunction, and others are important factors to treat, and subsequently dialysis prescription and non-pharmacological behavior and modification of hemodialysis, in particularly the convection therapy to remove the cytokines. So the technical intradialytic strategy, UF profiling, blood volume monitoring, hemodiafiltration, temperature biofeedback, sodium profiling, bioimpedance, and isolated ultrafiltration, all are measures tried to improve the intradialytic hypotension, while sodium profiling is prohibited because higher sodium is a risk. Inside that, limited evidence to support this approach for the isolated ultrafiltration, while blood volume monitoring has a prognostic value, and for sure hemodiafiltration is the golden standard to remove the cytokines as well as the inflammation. So this is the maintenance hemodialysis and acute kidney injury. Both have different pathway in hemodynamic instability in hemodialysis patients, while AKI frequent in critical care may affect recovery by organ standing. So health, this is the intradialytic hypotension is not only associated with higher in hospital mortality, but may also be associated with decreased kidney recovery. If the patient has frequent hypotension during dialysis, the kidney recovery will be more delayed. Again, we have to look again in the patient ICU, the most importantly, the inflammations as well as the cardiac condition. In the same way, we have three main factors are important. The serum albumin, the plasma oncotic pressure, and the plasma refilling rate are important in deciding the ultrafiltration profile and to prevent the hemodynamic instability during renal replacement therapy. This is called the plasma refilling rate, and the plasma refilling rate are changeable. We have to mention that there is a lot of cardiac decompensation during the intradialytic hypotension, mainly the reflexes like basal gyrus reflex originating from the inhibitory mechanoreceptor in the left ventricle, poorly filled ventricle, and can induce bradycardia, vasodilatation, and hypotension. The resting wall motion abnormality in the myocardium due to ischemia or inflammation are significant, and this can predispose as well for intradialytic hypotension. So association of intradialytic hypotension and ultrafiltration with AKI dialysis dependent is important to decide because on a long scale that the recovery even after 3 months of the dialysis in AKI, the patient recovery is not intact. What about the plasma refilling? Plasma refilling means substitutions of the intravascular component by the interstitial fluid, and it is mainly due to fluid removal, ultrafiltration, increase in the plasma oncotic pressure due to concentration deficient and serum albumin, and on the other hand, no intradialytic hypotension due to oncotic recall of the water from the interstitium. So it says ultrafiltration, low serum albumin can induce intradialytic hypotension. Increasing that, the prolonged dialysis time is important because you have to make a smooth ultrafiltration, and when refill lags behind ultrafiltration بيتأخر حوالي نص ساعة من بداية الالترافiltration بنلاقي ان في increase الهارت ريت myocardial contractility peripheral vasoconstriction release of vasoactive mediators like insulins plasma proteins increase heme concentration and trying to fill. If failing that, we know that the aquaporins and the water channels, and we can manage that situation by the blood volume monitoring during hemodialysis. You can test the hematocrit online, and you can stop ultrafiltration once it is significantly higher. This is called hematocrit-based ultrafiltration, as many of the supply of the technology in that, and it can prevent intradialytic hypotension. We have to measure that the relative blood volume drop. We have increase in the oncotic pressure, so we can compensate that. So ultrafiltration lead to increase in plasma oncotic pressure and subsequently can remove more water. Again, we have to test serum albumin post dialysis, not pre-dialysis, because of the concentration effect. Poor plasma refilling, like in diabetics and autonomic neuropathy, is another مشكلة. Eating on dialysis is a very important to prevent that during dialysis for intradialytic hypertension. We can infuse saline at the start of hemodialysis and we can manage them. However, the cardiac dysfunction with renal replacement therapy in hemodynamic unstable renal replacement therapy will follow the Frank-Starling law, what means that increase the dimension of the ventricles by volume overload, we have decreased cardiac output due to stretch. So this is what's called the D-shaped heart because of the ventricular compression by the right ventricle towards the left ventricle and subsequently lower cardiac output and intradialytic hypotension. So the transcapillary usually follow the ultrafiltration with a lag period of about half an hour, and it is usually in the association of between 4 to 6 milli per kg per hour. So this is the intradialytic hypotension, whatever your definition, systolic pressure drop, and hemodynamic instability due to acute kidney injury is very important because it affects the recovery of the injured kidney in AKI, increased preload and decreased cardiac function associated with overload is significantly in patients in critically ill in the ICU. And this is very recently publications, and depending that volume overload can induce sudden increase in the ventricular volume. Diastolic stretch can induce mechanoelectrical feedback. Patient can have ventricular ectomy, ventricular tachycardia, and ventricular fibrillation with a heterogeneous activation of transmembrane ion channels and impaired finally the cardiac function. And all these are importantly in critically ill patient. Why CRRT and other modalities can improve? Yes, because you can remove the cytokines and uremic toxins accumulated in patients with acute kidney injury. So finally, we have to conclude. And conclusion depending on our clinical experiences as well on the literature. Unfortunately, the literature of IV albumin inside that is not so much. We know that low serum albumin perfectly describes the mortality and the morbidity and the predictor. However, albumin infusion is not enough. Generally, we cannot give IV albumin and all the problem had been solved. So IV albumin is one step to improve, but is not the total recovery or patient improvement. Subsequently, we have to treat malnutrition, inflammation, complex syndrome, and giving human albumin 20%, just increasing 3.5 of the albumin infusion by water. For example, if we are giving 200, which is a big dose of albumin, the vascular compartment just increased by 700 milli, and this is within 15 minutes. So we have to important consideration what is the cause of intradialytic hypotension. Not all causes are second to volume depletion. Patients with serum albumin, we have to give IV albumin if the patient has low serum albumin, cost and benefits and risk of the huge money paying for human albumin, as well for the risk of contamination, infection, or aluminum toxicity. So the protein enriched snack is important. We have to increase the protein content, because increasing the protein content snacks will increase the serum albumin predictably, plus other essential amino acids. The randomized trial of albumin infusion to prevent intradiabetic hypotension, few studies on that, and usually giving some important points if the serum albumin is below 3 grams per deciliter. Comparing the IV albumin infusion towards the normal saline in most of the studies are not significantly predictor of improvement. You can find that these studies, as well many other studies, giving some conflict between partial improvement and no improvement. So the number of episodes with need for discontinuing ultrafiltration during a dialysis session toward giving IV albumin, provided that the serum albumin is below 3. The episode of hypotension with ultrafiltration discontinuation is much better with patients IV albumin given immediately before the dialysis session, and the prescribed and delivered ultrafiltration volume are better with lower hypotension episode towards the patient receiving IV albumin prior to the dialysis session. So a lot of studies, this is one of the rich studies on the rat with calculation to attract a total of 18 milli of water per 1 gram of protein. كل 1 جرام of albumin هياخد معاه 18 مللي من interstitium to expand the intravascular volume. A lot of trials and potential risk of albumin, including unnecessary fluid accumulation, aluminum toxicity, infection, and the other, besides, of course, is the cost of IV albumin infusion. A lot of study as well assessing the intravenous albumin for the intradialytic hypotension. Correlation is not directly because you have many factorial effects as well inside the hypotension, including inflammation, malnutrition, complex syndrome. So IV albumin is good, but it's a very transient. 5 randomized controlled trial on 4 observations trial were included in patient, and the use of lower diuretic temperature is much better even if you are giving IV albumin for the intradialytic hypertension. So in conclusion, Mr. Chairman, my colleagues, I have a road of in the pathophysiology, the cardiac effect, the role of hemodialysis or renal replacement therapy induced hemodynamic instability. One of the factors is low serum albumin, but low serum albumin is just a figure, it's just a number. Whatever the cause of low serum albumin is important to treat, and subsequently we have to treat all patients directed toward improved nutrition, removing cytokines from dialysis by convection therapy, as well increasing the expanding our knowledge about the albumin transfer through the trans dialysis membranes and albumin loss in membranes with huge albumin loss. So the strategies for reducing hypoalbuminemia in maintenance hemodialysis population include improving systemic inflammation, preventing infection, optimizing nutrition state, and ensuring the appropriate management of comorbid condition. Giving IV human albumin could be of value to improve fluid removal. However, it is a transit way toward a global improve in the overall patient morbidity and nutrition status. Be sure that intradiabetic hypertension and escaping and dialysis fatigue, as well making hemodialysis easier and convenient. Frequent intradialytic hypotension affects the hemodialysis adequacy from frequent closure. And finally, thank you.